All right, here we go. All right, good afternoon, everybody. Welcome back to our Friday webinar. I just wanted to take a quick moment, and it would be remiss of me to not mention how different our worlds have changed over the last 2 weeks in the state of Minnesota and internationally. So I know at Abbott, we just finished our tribute to George Floyd outside with 8-minute 40-second moment of silence, and it's a long time to have silence, and I can't imagine how much longer it felt to George Floyd. So I guess I just want to use this as an opportunity to remind people to use our role as healthcare workers, both at the hospital and the community, to try to change the systemic racism that is so present in our community at large. So with that, I will let Rachel Lanasa talk, and then I'll present after her, and then Dr. Anthony from the Central Lab and Dr. Iyer from the ambulatory side of things will present about lab testing updates after that. So Rachel, go ahead.
All right. Good afternoon, everybody. We will get started. So today, we're going to talk a little bit about epidemiology. We are going to talk about racial disparities in COVID-19 disease because I think it's a very important topic. And then we'll go over some treatment updates. So my part will be relatively brief today because we've got a full talk with other presenters today. So we'll get started with the epidemiology. And so in the United States, so we're up to 1.8 million cases with about 100,000 total deaths in the United States. Overall, there have been more than 6.3 million reported cases worldwide, with now kind of some hotspots emerging in Latin America, Africa, and the Middle East. It seems that there is some escalation in number of cases worldwide. Twice as many countries have reported a rise in new cases over the past 2 weeks, as have reported declines. Worldwide, there have been about more than 380,000 reported deaths, with more than a quarter of all those in the United States here, as you can see. In Minnesota, so we're up to 26,000 cases with about 1,000 deaths. Once again, most of those amongst patients who are residing in long-term or assisted care facilities. Oh, excuse me. Sorry about that. And I just wanted to mention, in the setting of the protests that have been, vigils that have been going on over the past week or so, the Department of Health and the City of Minneapolis is now recommending that anybody who is attending a protest or a vigil or a community cleanup get tested for COVID-19. They say even if you are asymptomatic, they're offering tests. They're recommending no later than 5 to 7 days after the event, and to consider being retested if you are re-exposed. And so you can go to the City of Minneapolis website to access testing. So I think this is something that's going to be really important moving forward. So we'll move on. So I wanted to talk today about racial disparities in COVID-19 disease. And so this is something that we are getting more data out as time goes on, and there are studies that are looking into this. So hopefully we will have more to share over the next couple weeks and months as we collect more data. And so we do know that Black and Latino populations do comprise a disproportionately greater number of reported COVID cases and deaths compared to other Americans. So this was all kind of initially being described a couple months ago with that MMWR report that I had talked about a couple months ago, where they looked at 580 hospitalized patients with COVID-19, and they found that of the patients who had reported race, 45% who were hospitalized were white versus 59% in the community, versus 33% of the patients who were hospitalized with COVID-19 were Black versus 18% in the community, which suggests an overrepresentation of Black patients amongst those who are hospitalized. There is a COVID-19 race tracker that is online available, and I highly recommend going onto it. I have the citation down below, covidtracking.com, and they've got a dashboard looking at COVID-19 cases and deaths as broken down by race. And they have described that African American deaths from COVID-19 are nearly 2 times greater than would be expected based on the share of the population. And actually in 4 states, the rate is 2 to 3 or is 3 times or more greater. In 42 states plus Washington, D.C., Hispanics and Latinos make up more than their greater share of confirmed cases than the share of the population, and in 8 states is more than 4 times greater. So once again, supporting that there is this disproportionate burden of cases and deaths amongst the Black and the Latino community. Here is just in New York City. They've been trying to report their data based on race and ethnicity, and here are age-adjusted rates of COVID-19 per 100,000 by race ethnicity. And you can see that Blacks and Latinos have a higher rate per 100,000 of COVID-19 cases and of those hospitalized and those deaths. So as far as kind of other minority groups, so Native American data is harder to come by, but by states in New Mexico and in Arizona, Native Americans have accounted for a higher proportion of cases and of deaths versus their actual population share. And there have been some described also overrepresentation of Asian Americans in COVID-19 cases. This is this is data that's looking at kind of county-based cases. And so this is, on the left is the COVID-19 race tracking data, and they are looking at either white versus predominantly African American counties. And so this is, they're counting them at the counties as predominantly African American or Black if they have a greater share than 13%. And you can see that the counties with the 20 highest death rates are amongst these communities, so these predominantly Black communities. And then on the right is a paper that was published about a month ago looking at the differential impacts of COVID-19 on Black communities. And you can see, so up top is the COVID-19 diagnosis and down below is the COVID-19 deaths. The orange counties are disproportionately Black counties versus the blue, which is all other counties. And then you can kind of see as you kind of get darker, you're getting to higher rates of diagnoses and then higher rates of deaths. And so you can see that there's a huge number of dark, so higher rates of diagnosis or cases amongst the orange, which is the disproportionately Black counties. And so that this will bring us to our Minnesota data. And so here we can see that so far there is race data that has been reported for 79% of the cases, 72% of the deaths. And once again, this is this COVID tracking project. And you can see that so Black or African Americans make up 6% of our population in Minnesota, yet represent 29% of our COVID-19 cases, and 8% of deaths. So our community, we're seeing the same thing that is happening nationally, where there's a disproportionate burden amongst the Black community of COVID-19 disease and deaths. And so why is this happening? And so this is something that there is active research that is going on. Right now there are some proposed causes for this. And I think at the end of the day, this is all deeply, deeply rooted in the institutionalized racism that exists in the United States. And so living conditions are something that I think that really kind of informs COVID-19 infection rates, as we know that this is easily transmissible amongst households. And so racial and ethnic minorities are much more likely to live in a densely populated area. There is residential housing segregation that exists. Minority neighborhoods are usually further from grocery stores, medical facilities, making supplies and seeking care more difficult. We think that probably multi-generational dense housing conditions are more common amongst certain minorities, ethnic minorities, which would make, once again, social distancing difficult and potentially more contact between kind of younger generations and older generations. And we do know that these older generations are at higher risk for morbidity and mortality from COVID-19. And we also know that racial and ethnic minority groups are overrepresented in jails, prisons, and detention centers, which are congregate living settings in which we are seeing huge amounts of infection of COVID-19. Work circumstances is something else that's really important. Because we presume that the risk of infection is greater for our essential workers who are working despite the outbreak and are often working in kind of denser conditions. We do know that people of color make up the majority of essential workers in food, agriculture, and in industrial, commercial, and residential facilities and services. And we are hearing about these outbreaks amongst people who are working in meat packing, people who are working in the service industry, and we know that people of color make up the majority of these workers. Also, I think related to this is sick leave. At the end of the day, if you are sick and you financially are not able to take paid sick leave, I think that's something that makes that can continue to propagate the burden of disease on these communities. And so we do know that, for example, Hispanic workers have lower rates of access to paid leave. And so I think that is a major problem. And then also at the end of the day, underlying health conditions and lower access to care. And so we do know that there are existing health disparities that exist amongst these populations. And that I think does inform the morbidity and mortality of COVID-19, because I think the pre-pandemic realities of racial and ethnic disparities really affects how we're seeing the disease manifest amongst these groups. And so we know that compared to whites, Hispanics and African Americans are much less likely to be insured. And I'm sorry, I think that cut off there. And we do know that Black Americans have higher rates of chronic illness and higher death rates due to these chronic illnesses. And once again, most likely due to the systemic inequality that exists. And I think involved in that is difficulty accessing care. I think inherent distrust of the medical system, financial inabilities to be able to miss work. And so I think there are a huge amount of barriers here that are contributing to these ongoing disparities. And so at the end of the day, what can be done? And I think right now for COVID-19, I think there is a push to collect better data, better racial data, because we need to be able to monitor and track these disparities to do anything for them. And so I think there is definitely a push right now to collecting better data. And then I think dovetailing from that, I think we would be able to really provide a tailored public health response to better be able to provide care and to provide prevention services for these communities. I think moving forward to be able to link groups of ethnic and racial minorities to healthcare, to better testing is something that's really important. It's hard to do, and once again, I think this is all systemic, but I think starting with collecting data and education is really, really important. And for us as healthcare providers, what can we do? And I think at the end of the day, the best thing that we can do is educating ourselves on institutionalized racism, educating ourselves on what we can do within the context of the healthcare system. There is this national standards for culturally and linguistically appropriate services in healthcare, which is supported by HHS. And so there's a curriculum online that if you Google think cultural health, you are able to get to some curriculum that is available for us as healthcare providers to better educate ourselves on how we can help these groups be able to navigate the system. So that is more to come, I think, as we get more data and hopefully, as we're able to provide better resources for these groups. I quickly want to talk about a treatment update for COVID-19. We do have a new set of just kind of updated guidelines. There's really not much in terms of actual change to the guidelines, but is kind of more streamlined. So you are able to go on the ACAN and access this. And we have, so far as our remdesivir and our plasma, we have initiated 119 remdesivir courses across Alina, and we have 137 convalescent plasma patients that have been registered. Remdesivir is continuing to be allocated by the scarce resource triage team, and we are continuing to reach out to providers if your inpatient is if your inpatient patient is eligible for remdesivir. Once again, these patients need to be, verbal consent needs to be obtained, and they need to be given the EUA fact sheet on remdesivir. And so if anything changes, we will keep everybody updated, but that's where we're at this point. And I also wanted to once again, mention the HERO registry that is continuing to register healthcare workers for studies. There's currently a pre-exposure prophylaxis hydroxychloroquine study that is ongoing. And so if anybody's interested, go to this HERO website and you can join the registry. And as far as take-home points, you know, I want to kind of echo what Dr. Preble said, and you know, acknowledging what's happened over the past couple of weeks here, and acknowledging the systemic racism that exists, and it is a major healthcare issue, and so it's something that we should all care about. Rest in peace, George Floyd, and Black Lives Matter. Thanks.
Great. Thank you very much, Rachel. I thought that was important to talk about racial disparities in COVID, but also in healthcare in general. A couple questions while I get my slides up. What is Alina's stance on employees who have protested or helped in the cleanup? Should testing be mandated so as not potentially be spreading to colleagues and patients?
That's a great question. I don't think there has been a mandate at this point. I would probably just echo what MDH in the city of Minneapolis is saying, in that I would encourage, if you have been to a gathering, to be tested within 5 days at any of the testing sites. And then definitely I would just be really vigilant about looking for symptoms at home. You know, taking your temperature twice a day is never wrong to do. So I don't think there's been an official stance, but at this point I would echo what the state and what the city are saying.
Great. And let's do, actually, we'll keep going just in the interest of time. So I'm just going to try to make my slides a bit bigger. That did not work. Hold on one second. Okay. So I have kind of a number of clinically related things to go over, and mostly I'm not going to get into all the details of them, but want to make people on the webinar aware that these guides exist and these changes are being made, and then there'll be more information on our clinical guidelines website. So the first is that there's this COVID patient category grid that I want people to get more familiar with. And so basically we tried, this was a joint effort across the system and with a lot of input from Dr. Anderson with ID about how we can routinely talk about these patients from one continuum of care to the other. So symptomatic patients and asymptomatic patients, we're talking about the test results, which, you know, are pretty black and white. Some of these need the COVID suspicion taken into account. And then the big thing that I want to highlight is just this patient category. So I would love for all of us and kind of providers being the people who kind of start this and then spread it to the nurses, but talking about COVID positive patients, PUIs, and non-suspect COVIDs, because at least for right now, this table, we can break it down into those three. The terms that we want to try to get away from are the terms like screened for COVID or screening tests, because that gets confused with what we have been doing, what the nurses have been doing on admission and prior to any sort of interaction with the healthcare system, is that symptom and travel screen. So it's kind of ingrained in us, and it's not the wrong word, but it's just confusing. So if at all possible, talk about these in terms of COVID positive, PUI, or non-suspect COVID. This diagram and any updates to it are on our ACAN page. So just a reminder, yellow box, middle quick link where it says COVID-19 clinical guidelines, and then this one specifically is on the inpatient management page. That was the first thing that I wanted to update you. The second is that there's this AGP document, so the aerosol generating procedures document, and there is a system-wide group that receives all the SBARs for people that want to have changes made to this, to what is considered an AGP and what is not. And I get that this is a ever-changing document and additions are made, and there used to just be a couple columns and now there's more columns, but just make sure that you're familiar, especially if you do any of these procedures or could be involved with any of these procedures, that you are familiar with what PPE that you need. And so specifically, I want to call out that BiPAP and CPAP are now considered that you need respirator and eye protection in people without a COVID test, as well as intubation, extubation, and some other ones. So that is also on the inpatient management page, and you should expect that to change frequently. Sorry. So what this one is talking about is that CPAP and BiPAP used in untested patients. So we know that CPAP and BiPAP are aerosol generating procedures, and so a number of people were concerned, including myself, that using these aids in ventilation for untested patients leaves a lot of risk for transmission. And so as of this week, anyone who is going to be needing CPAP or BiPAP in an acute respiratory failure setting, so was doing fine and then either in the ED or on the floor needs this, should be placed automatically in enhanced airborne precautions prior to initiation of BiPAP or CPAP. And then a COVID test should be ordered using the PUI option. And then just kind of some reminders that CPAP and BiPAP can be done in any room. Ideally, it's a negative airflow room, but can be done anywhere as long as the door is closed, proper PPE is used, and then there's a AGP stop sign placed on the door. The other subset of patients is the chronic respiratory issue patients that use CPAP, BiPAP, usually for sleep apnea. And so we also got approval for all asymptomatic patients admitted to the hospital. So on admission, if you are planning on using a CPAP or BiPAP, that a COVID test be ordered using a different indication. And this will just bucket them into the right area so that people know and the test gets sent to the correct place. So pre-procedure, and just think of the procedure as being BiPAP or CPAP without previous COVID test and no COVID symptoms. So that person does not need to be an enhanced airborne, because our recommendation is that you don't use CPAP or BiPAP until that COVID test is resulted. And it's not, that seems like, why do we have to wait? But we're already telling, that has been our stance previously, is do not use CPAP or BiPAP in the hospital, period. So this is actually an improvement. We're just saying don't use CPAP or BiPAP until the test is resulted. And so there should also be a nurse communication order that says don't use it until the test is resulted, and that they should be on standard precautions while the test is pending, and then change them to the precautions based on the test result. So that's a lot to remember, and that's a lot of process issues. So as much as we don't like BPAs, there is going to be a BPA built for this to aid you in making the right choices. And so there'll be one for acute respiratory failure that you have to choose. And so there'll be the hopefully the enhanced airborne isolation precautions and the right order. And then if it's more of a chronic issue, then there'll be one for the correct COVID test and then nurse communication order. So RT is being educated on this, and as with anything, this is a rollout. It's not going to happen correctly every time overnight, but the goal would be by mid next week that this is common practice. So then the other one that comes up is CPAP or BiPAP use on discharging patients. And so it's come up a couple times where people who have known COVID who are being discharged to hospice are sometimes we routinely send them out on BiPAP, and that obviously has a big risk of transmission, especially if they're going to a home setting that's like an apartment building or such. So there are just some statements, and these will be in some guidelines that are going to be on the website shortly in the pulmonary section about don't send people with known COVID who are not expected to survive out on BiPAP. So either discontinue in the hospital or trial the discontinuation the day before the discharge. And then the last patient group I want to talk about was those who use CPAP and BiPAP in home settings. And so you can imagine there's a lot of people that this is going to apply to as well. And so if you're COVID positive in the hospital, what do I do when I go home? And so just educating them about there is this increased risk and potential transmission, and that they ideally should not use their CPAP or BiPAP at home until their isolation period is done. And then when that isolation period is over, that they should resume the use of it. So that's also an important part. We don't want people to stop these indefinitely, but they should clean it appropriately, and there are instructions. So a way to remember this will be embedded into the discharge order instructions for patients on the ABS next week sometime. But in the meantime, it'll just be a verbal conversation to have with each of your patients. So one of the kind of bigger practice changing things that we also want to talk about was DVT prophylaxis. And so just in general, and you've heard this on this webinar multiple times, but just to reiterate, we think that COVID-19 puts you at a higher thrombotic risk than other infectious diseases, and so pulmonary artery clots, but also there's been autopsy studies about pulmonary capillary microthrombi, and although we know that there's this increased risk, there's not a lot of data, i.e. well done studies to show how to prevent these, but all the guidelines do say that you should use some sort of pharmacologic VT prophylaxis in the hospital. And so the COVID clinical content group came out over a month ago saying, yes, do this. It's in all the order sets. So basically, Lovenox, either daily or BID based on your BMI. And then if your creatinine clearance is lower than 30, using unfractionated heparin BID or TID based on your BMI. We also came out and said that while we know other institutions are doing some of these kind of moderate or actually therapeutic dose anticoagulation as prophylaxis, even in the realm of low suspicion of VTE, we don't feel like there's enough data to support that. And so if you think that VTE is suspected, definitely go down your normal workup, and you should have a high index of suspicion for VTE in COVID patients, but we don't recommend kind of these hybrid regimens. So then we kind of get to the DVT prophylaxis in the outpatient world, and that's where we have some new guidance, not from studies, but just from ALINA. So we know there's a Magellan trial, and I don't have time to get into all the details, but basically rivaroxaban proved to be slightly better for symptomatic DVT compared to Lovenox, and that was 35 days of rivaroxaban versus 10 days of Lovenox. There was another one about apixaban that actually didn't show any benefit compared to Lovenox. And there's one other one, the Apex trial about bitrixaban, which did show benefit, but just is not that commonly used of a medication. We far more use rivaroxaban. And so for what will started in the order sets today, in all of the discharge order sets that have the COVID discharge instructions, is that we are recommending, as ALINA, saying that we should use pharmacologic DVT or VT prophylaxis in patients who have a low bleeding risk if you're discharging to a TCU, an acute rehab facility, or the home hospital care program, and that you should consider using pharmacologic DVT prophylaxis if you're going just discharging to home or traditional home healthcare. So those medications, obviously rivaroxaban would be the easiest, is 10 milligrams daily for 30 days. We kind of had to pick a duration, and 35 seems awkward to try to get refills, so 30 days seems sufficient. And then if that's not covered, if that's for whatever reason the patient can't do that, then the only other options that we felt like could be viable options were Lovenox and unfractionated heparin. I know there's going to be lots of questions about that, and for the discharging people, mostly hospitalists, there will be more education about this, but I just wanted to make sure people were aware of this practice change. There is a algorithm that kind of spells that out in pictures as opposed to words. And then the last thing that I wanted to touch on was this half-face respirator rollout for Alina. And so we are changing most of the people who are on the 157 and 95 plan over to half-face respirators. And I had no idea what these were, and so I just wanted to give you guys a little bit of education about them. But basically, they have an inhalation valve and they have an exhalation valve. And the inhalation valve has a P100 filter, so actually slightly better than our N95s. And the exhalation valve is somewhat filtered. I wasn't able to find the exact amount of filtering. And I know everyone has a little bit of hesitation to take anything that the CDC says as the word, but the CDC does allow these and says that they provide at least equivalent protection to the N95 mask that we have been previously using. And so logistics on this, there is a LMS module. I did it last night. It took about 5 minutes. I found it very helpful. So prior to fit testing, if you're going to be in this patient or in this group that's going to get one of these, please do the LMS module and just search half-face respirator. Like I said, these are the staff that are going to be kind of expected to switch over to these respirators. It is yours and only yours. So you get this, it should last you however long until it breaks. The filters can last up to a year. And they will go over how to decontaminate it and things like that. And then I know there was a question originally out there about sterile areas. And while we are still saying that they cannot be used in the ORs because of the theoretical risk of exhaled air contaminating the field, they were just approved by the system level infection preventionists and ID that they can be used in other areas that do sterile procedures such as the ICU and the ED. So that is a little bit of a change that I wanted to call out. So that is a whole bunch of information, and hopefully some of it will stick, and look for more information to come in the emails that you've been getting from the system. All right, I'm going to let Dr. Iyer load up his slides. I'm going to try to read through some of these questions. I guess there's one, Rachel, that I'm going to throw to you and Dr. Anderson about, are you reviewing patients for us or only with an ID consult?
Sorry, I was on mute. What was the question?
Just, does the remdesivir screening for eligibility happen automatically or only if you have an ID consult?
Yep, it happens automatically. Yep, we're screening all COVID positive patients in the hospital. But you are welcome to get an ID consult if we contact you and say that somebody is eligible, and you don't feel comfortable with it. That is an option.
And then I'm just going to touch on a couple of the CPAP ones. What about post-surgical patients who had a negative, I think, test prior to admission on chronic CPAP BiPAP? Does that test already count? Yes. So we are saying the look back is 14 days for that test. So if they had, for sure, that includes all those pre-op patients that got theirs within that 4 to 6, or I think 2 to 6 day time window prior to surgery. And then is there a recommendation to hold the outpatient CPAP or BiPAP if COVID positive part of the RN resulting info? Not yet, but we're working with the ambulatory side to make sure that gets communicated as well. But thank you for for that question. All right, Dr. Iyer and Dr. Anthony, I will let you guys take it away.
Sarah, can you see my slide? Complete
Yes.
screen?
Yep.
All right. Well, thank you, Sarah, for giving us the opportunity to talk about this topic, which has raised a lot of questions, and hopefully we can provide some clarity around it. I need to specifically thank Dr. Lauren Anthony and Heather Dawson from our lab services who have helped me in putting the slides together. Um, I have no financial disclosure, but I feel one disclosure or disclaimer that all of us need to do before talking on any COVID topic is that whatever we say today is bound to change tomorrow. It's a shifting field. I have realized that I have to learn, relearn, and unlearn, and then learn again. So just be careful that you have to keep updating yourself. What we hope to do, hopefully in the next 20 minutes, is to give you kind of quick overview on what are the diagnostics tests available for COVID-19, how to interpret them, how to talk to your patient about those results, and at what stages in the disease, which test is more applicable, and talk a little bit about RT-PCR and serology. So these are the four main tests that are available for diagnostic tests for COVID-19. The first two are basically called as a molecular test or the nucleic acid test, the RT, the PCR, reverse transcriptase polymerase chain reaction, and the point of testing nucleic acid amplification test. RT-PCR, of course, we are well aware of as providers. It detects basically minute amounts of the COVID-19 virus RNA, which is amplified in varying temperatures. And this RT-PCR test is highly specific because we used two primers, and these primers target at least two regions of the viral RNA, and therefore it's highly specific and doesn't detect the RNA of other non-COVID coronavirus, the common cold viruses. Also, there is internal control, which is basically human RNA, because we have to remember when we collect the nasopharyngeal swab, that swab will contain human cells as well as the viral RNA. So if you are able to detect the human RNA, we can be confident that the sample was adequately collected. The point of care testing for the nucleic acid amplification test is similar to RT-PCR, but it has low complexity, pretty quick turnaround time, usually within an hour, and is CLIA waived. That means we can do those tests in a non-laboratory setting. And I've given you some examples on the slide, Abbott ID Now and Cepheid. These are the point of care testing. Serology is the third test that is put up on the slide, which detects antibodies, IgM and IgG. Antibodies that a body forms against SARS coronavirus. There are various technologies used to detect these antibodies, right from ELISA to lateral flow assay. And the one that Alina is going to use is the chemiluminescent immunoassay. In research labs, they also do neutralization assay, where they actually see whether the antibody can inhibit the plaque growth of the virus in cell cultures. And the last test is the antigen point of care testing. This is the best way to explain this is a test similar to the streptococcal throat antigen swab test that we do in our routine practice. So there are monoclonal antibodies developed against the viral antigen, usually the surface antigen, the spike antigen. However, as all antigen testing, this is also plagued with suboptimal sensitivity, and therefore this could be a good screening tool when it becomes available widely. Right now, there are only few tests available, but if this test is negative and your suspicion is high for COVID-19, you will need to do RT-PCR. So on this slide, I just want to highlight at the end of the day two important things. One is RT-PCR is the gold standard for using to detect acute infection, and serology will detect past exposure, usually 14 days in the past. What I want to show in this slide now is basically an animation, and hopefully I'll spend some time a little bit on this because this slide will probably cover the next following slides, so I can go through next slides faster. So what I'm showing right now is a life cycle of the COVID-19 infection. So right here, we are showing that, say you have been exposed to SARS-CoV virus, then between the exposure and this black dotted line is the onset of symptom. That time duration is the incubation period, and we all are aware that it's around 14 days. Median is 5 days. So, and then once the symptoms start, these are the weeks after the symptoms have started, 1 week, 2 week, and so on. What I'm going to do is basically on this graph, I'm going to superimpose certain probability curves, uh, specifically for the RT-PCR and for the antibody testing. So remember, these are probability curves and not curves showing density or the concentration of the agents. So the first curve that I'm going to show here is the nasopharyngeal swab for RT-PCR. And as you can see, the probability of finding a positive RT-PCR test is high within the first week or 10 days after onset of symptom. If you're lucky enough to do the test few days before, even 2 or 3 days before the onset of symptom, even then you can find it. Uh, and studies have clearly shown that the RT-PCR test probability of finding that positivity goes down as the number of weeks after the onset of symptoms increases. So to the extent that by around 3 weeks, it's only 60% chance of finding it positive. By around 5 to 6 weeks, it goes down to less than 5%. Few key points on this graph. One is RT-PCR, if it is tested earlier on in the disease course, meaning within the first week or 10 days, it is highly likely that it will be positive. However, you also have to realize on this curve that RT-PCR in small subset of patient could be positive for a number of weeks, usually even up to 30 days after the resolution of symptoms, that it still may be positive. The question is, does RT-PCR positivity correlate with infectivity? And people often tend to forget that RT-PCR detects the RNA and not the intact virion particle, which is the infectious particle. So I'm going to superimpose another curve here. This green curve, this is actually the curve showing the probability of isolating the virus in vitro cell lines. So as you can see, the probability of getting the virus in culture is highest in the first week, i.e., most of the studies that have been done so far have clear, and especially these are meticulous tests done where they have done serial RT-PCR on various sources of specimen. At the same time, they have tried to grow the virus in culture. Most of the studies have shown that after around 8 days of onset of symptom, we are unable to grow the virus in culture. What does that mean for us? It means that if you have done an RT-PCR in the earlier in the course of your illness, that RT-PCR positivity will be high, likely that it will be positive, and it will correlate with infectivity. However, with the same token, if you are 4 weeks out, 3-4 weeks out of the onset of illness, your RT-PCR in a small set of patients may be positive, but you're not able to grow the virus. So that means they are not infective. And here is the problem where we differ between the recommendations given by MDH or CDC, where they kind of insist on a test-based strategy, where one of the recommendation is you can discontinue isolation precautions if you have at least 2 RT-PCR done 24 hours apart and if they are negative. The problem with that is some patients may be RT-PCR positive for a longer length of time, and a lot of resource would be wasted. Practically, what we recommend is to follow the time-based strategy, which basically says that if you have passed 10 days, and as you can see here, once you pass 10 days after onset of symptoms, the likelihood of growing the virus in culture is really does not exist. So if you are passing 10 days after onset of symptoms, and if you have had 3 days of resolution of symptoms, then you can be considered as recovered from the viral infection. So that would be the time where discontinuation of isolation would be possible. I'm going to superimpose 2 more curves in here, which are the antibodies, so-called seroconversion. So as you can see, the antibodies will start developing. Actually, this curve should start a little bit even ahead here somewhere. So the antibodies start developing in the course of illness around 5 days to 7 days, and the probability of finding the antibody positive is highest around 2 weeks. And then the probability starts to drop down. The purple dotted line is the IgM and the blue dotted line is the IgG. Something unique I want to point out here, which is specific for the corona COVID virus, which is different than other viruses, is that the IgG and the IgM antibody usually come up simultaneously in COVID-19. And that's advantageous because IgG antibody test is more specific than IgM. IgM has a little bit of issue with sensitivity and sometimes can cross-react with other non-corona COVID viruses, the common cold viruses, and therefore at Alina, which the test will be available from June 8th, would be the IgG antibody test. What I want to show on this slide is basically to remind everybody that detecting the viral RNA and RT-PCR does not always equate to infectivity. And this is the infectious particle that you see in the left corner, which is the intact virion, whereas what I'm showing here is the viral genome. And as we just said, RT-PCR is a highly specific test. The reason being specific is that we use two probes to identify at least two regions on this mRNA, on this RNA. And therefore, when you detect two regions, you become very specific and you don't detect other RNAs. We often get asked about sensitivity and specificity for RT-PCR. As we just said, the specificity of RT-PCR is almost 100% because of using the two probes. When you discuss about sensitivity of RT-PCR, that is not yet established. And the reason for that is we have to understand there are two terms for sensitivity that we use often. One is analytic sensitivity and other is clinical sensitivity. What I mean by analytic sensitivity is if we assume that your specimen contains adequate amount of the viral RNA, then how good is your test to detect that? But the assumption is your specimen to begin with has adequate amount of viral RNA, and then how good is your test to detect that? And PCR being highly sensitive, the sensitivity, analytic sensitivity almost approaches 100%. Whereas clinical sensitivity, we often hear about false negatives, and clinical sensitivity is alludes to that. What it basically says is how much does your specimen have adequate amount of RNA, viral RNA, and that will depend upon not only the viral load. It depends upon what time of the illness that you have collected. Have you collected this specimen early or late in the course of the illness? It depends upon your collection techniques. So when you hear that RT-PCR was negative, which is doesn't mean that the technique was inadequate. It means your the collection or the viral load was inadequate. And I've given a link at the bottom for those people who want to really know how RT-PCR is done. Sorry, I went off my screen here. Let me, oh, there we go. We also get often asked to differentiate between sensitivity for various specimens that we collect, nasopharyngeal, oropharyngeal versus nasal swab. And the short answer is they're all pretty equivalent. The only problem is a lab can only do swabs which they have been approved for by the FDA under EUA authorization for that particular platform and that particular specimen. For example, nasopharyngeal swab pretty much is universally accepted and they have been approved. Whereas oropharyngeal swab can only be done by those labs which have done what is called as parallel validation study, head-to-head study, comparing the nasal pharyngeal swab and the oropharyngeal swab. And from our reference lab right now, Mayo and Hennepin County Medical Center are the only two centers that can do the oropharyngeal swab in addition. Going on to the serology test, we've mentioned most of it, but I just want to highlight a few things. One is that the serology test cannot be used as what is called as immunity passport. What I mean by that is just because you have a positive serology, we do not know whether we are detecting antibodies that confer immunity, and even if they confer immunity, what is the extent and how long does it last? So there's a lot of unknowns about this and still research being done. But initial reports do indicate that these antibodies could be protective, at least for the short term. The reason is we have seen in primate models, they are protected from reinfection. And the other key, as you saw in my animation, as the antibody titer starts coming up at around 2 weeks peak, the RT-PCR starts to go down. So indirect evidence that probably those antibodies could be protective, but we are not sure of that. At Alina, we are going to start doing the offering the serology test. It's Abbott's Labs SARS-CoV-2 IgG antibody assay on Architect instrument. Again, it will detect, as I said, IgG antibody. And we have been asked what is the sensitivity and specificity of this test. Preliminary, and Dr. Anthony shared their report, those data with me. We did 54 validation study, 54 patients in a validation study, and what we found is the specificity is, the sensitivity, I'm sorry, is almost 100% at day 14 in our lab. The biggest study done of the at University of Washington in Seattle showed that sensitivity is 97% at day 14 and 100% at day 17 after symptom onset, and that sensitivity and specificity is almost 99.9%. So in short, it's a highly sensitive and specific test. Next two slides I'm going to skip because these are the studies which basically, if people are interested, they can click on the hyperlinks and get into more details about the viral load test that I was saying, that the virus was not isolated after 8 days of onset of symptoms. So hopefully this would be my last slide. What are the indications of antibody testing? We are very clear that the antibody testing, at least the small niche of patient who will be benefiting maximum are those patients who are symptomatic, presenting late in the course of their illness, i.e. 14 days after the onset of symptoms, and they have either had a negative RT-PCR or for some reason could not get RT-PCR. So bottom line is antibody test is to be used predominantly 14 days after the onset of symptom. What we are planned to do from June 8th, we are introducing the test in phase 1 and phase 2 format. Phase 1 would be only available for hospitalized patients, and phase 2 will then, after several weeks, expand it to ambulatory patients. There are certain other indications for using the test, like for using it to identify convalescent plasma donors or for public health surveillance to know the prevalence of the disease in the community. Both of these indications are out of scope for Alina, so that won't be our indication to do the test. And about immune status, I already mentioned that we are not sure about the antibody protection offered, so it should not be used either to determine which healthcare workers can come back to work, or we cannot even use it to allocate PPE. This would be the screen. I just took a screenshot. Dr. Dave Ingham sent this to me, that if from Monday when you start ordering the test, you'll see this come up on your screen, basically reminding you what the indications are. And that would be a hard stop, I think, if you order the test before 14 days, the order may not go through. So take-home message is the RT-PCR test is highly sensitive and specific. It is best to do the test within the first 7 to 10 days. You can extend it up to 14 days after the onset of symptoms. And remember that RT-PCR can be positive in a small subset of patients for a longer length of time without being infectious. And seroconversion is 100% per day 14. That's all I have, and I will stop here. Lauren, if I missed something, do you want to add? Dr. Anthony, if you're on, yeah. You may be on mute.
Can you hear me?
Yep.
Okay. No, thank you for covering that, and I really appreciate Dr. Iyer's partnership in this, and he's going to be working with the ambulatory division too, because right now serology requires, it requires a blood draw, and in our ambulatory centers, we are overbooked for patients who need blood work for other reasons. So at this point, we really can't open it up in the ambulatory area until we have the ability to collect more specimens. And also right now, the CDC has come up with multiple releases of guidance. The most recent guidance they gave on May 23rd did specify that the indication that we're approving it for symptomatic patients who are presenting late with symptoms that started more than 14 days ago is the indication that has some clinical utility other than the ones that are, like blood center testing for antibody or surveillance. So for clinical care, they are recommending that one indication, and so that's the one that we've approved it for here. And the test code is going to be lab 14331. And again, we're restricting it to inpatients just because of the capacity issues with outpatients, and also to allow for education as well, because there's a potential to tie up a lot of resources with testing that's not going to provide a clinical benefit at this point. So just to let you know, so and I'm sure there will be questions about this, but again, this is how we need to roll it out. It won't be forever for phase 2, but we expect in a few weeks we'll have more sites open that could handle more blood collections. But right now we're overbooked, and we have to consider that along with the fact that the test still has very limited clinical utility. However, we have seen cases where the information would be useful. The one case where it was ordered, for instance, was a young patient who came in and was with severe acute lung disease. They thought perhaps it was vaping induced injury, but then the patient denied vaping. They had 4 different negative PCRs and had been in the hospital over 2 weeks. So just to clarify a clinical picture and to see whether COVID was even a possibility, the test was done and it was negative. So it can help clarify complex clinical pictures like that, but in and of itself, it doesn't have a standalone utility. The test we're bringing in is basically the best available. So we've chosen a good test, and because there are so many bad ones out there, we did a very rigorous validation of it just to see what its real world performance would be versus the claims. So we feel that it does what we're seeing in our study matched up with what the claims are. So we'll see how things go, and hopefully this will be an aid to diagnosis in some, but doesn't have a lot of standalone utility at this point.
Thank
Great.
you, Lauren. And
Thank
the
you.
CME slide is up for people to see.
I have one question that came up about, and I don't know, Lauren, if you're as familiar with the logistics of how the testing is offered, but I think it gets to the fact of how are we determining that the asymptomatic people that we're offering testing to are, like, do you have to say that you are a protester? I think is what the question is getting after, because that would also, maybe lead to some distrust if you had to say, like, I was protesting this before you're able to get tested. Do you have any knowledge of the logistics of that?
Well, I saw in the chat that somebody brought up that here on the Abbott campus, in that parking lot next to Penny George, they are going to open up a PCR collection site. So there are a few logistics to work out for that. There's a lot of administrative work that goes into managing these collections and results to get the right result to the right patient and preserve specimens and to track it through the system, especially since we have to send out the majority of our tests. So
but do they have to say, I guess, are we
no,
opening it up to
no,
all
like,
asymptomatics? Or do
no,
they have to say, I was a protester? Like,
I
is that a part of the screening question?
I don't believe it is. I think they're going to be accepting walk-ups as
Okay.
well as patients who make appointments for reasons, for either the reasons that we have people going to drive-ups for to begin with, and then the plan is to also accept walk-ups. But we don't have a go-live date. They want it to be as soon as possible, but again, you want to get samples intact, you want to log them through the system, you want to be able to track them, you want to be able to call the results, and you want the right specimen label to get on the specimen to be tested outside, and then for the results to come back to the right place. there's a lot of administration work to that. So all of these curbside centers have had a lot of administrative work to get them ready. So this one, we don't have a go live date. I know we want to do it as soon as we possibly can. The lab manages the specimens. The actual collections are performed by our clinical teams. And I'm not personally involved in the scheduling of those, but I don't think there's going to be, I don't know if that question is going to be asked or not, or if MDH is asking them to ask that. Yeah, sure. Thanks.
That was brought up at a prior meeting, and wording is being crafted to be sensitive to not identifying a person as being in a particular group. So we are going to try to be very sensitive to that.
Great, thanks, Dan. And then Dan, while you're on, there was a question that I think that you have some opinions about nursing homes that are asking for not just one, but 2 negative PCRs, and how that's, you know, delaying discharges, and we don't have the resources to do that. What are your feelings about that?
Well, like Dr. Iyer pointed out, the difference between the timing of a positive culture, which indicates likely contagiousness, and a positive PCR, they can be weeks apart. I wish that centers would accept a time or symptom-based strategy for clearing from transmission-based precautions. Right now, they don't. It's an issue that's been brought up to the State Department of Health, and we're trying to work on this at a statewide level, trying to be sensitive to the accepting facilities wanting to be extremely cautious, but also trying not to back up people and keep them in the hospital unnecessarily.
Sure. And I think we'll do one more, because there's 2 people who asked this kind of similar question about a pattern of cycling of fevers, mostly at night, in COVID positive patients. I guess that's the first question. Is that something that you and Dr. Lanasa are seeing for your consults? You're on mute.
Sorry, I was on mute. Yeah, I mean, anecdotally, I feel like I've seen it, but I haven't seen it described in any capacity yet.
Okay. And then there was one more about someone who has a outpatient with a COVID typical syndrome, but serial RT-PCR negative tests, and with ongoing cycling low-grade fevers. Is there a mimic, or I think that brings up 2 questions. Should we be doing serial RT-PCR tests in the outpatient setting? And then 2, is there a mimic out there?
I mean, I guess I wouldn't do serial repeat PCRs as an outpatient, especially, I mean, if it's not going to change management. And I mean, are there mimics? I mean, there are definitely other respiratory viruses that are still circulating and circulate year round that can definitely present similarly to COVID-19. So that, that would be a consideration.
And also, if it's a pediatric population, the multi-system inflammatory syndrome in children or non-infectious vasculitides and other things as well.
Lauren, did you have something?
Well, that might be a case where the
serology.
The serology could be an adjunct piece of information for that. But also, we did talk about anyway too, retesting guidelines in the outpatient setting. This patient was seen multiple times, but we're also going to, for patients setting up appointments to come in, we're also, if they've had like a different illness and that now they have another illness, we're going to require a virtual visit before we keep retesting somebody who had, says they were sick, had a negative test, they got better, now they're sick again. We'd have a high suspicion that something else was going on, and so forth.
Sure. All right, great. Well, thank you all for joining in again. I'll have the webinar up on our AKN clinical guidelines page this afternoon, and then the Q&A will be on Monday, and then we'll do this again in 2 weeks. Thank you all.